All right, so good afternoon. We'll go ahead and get started. I am Sharita Golden. I'm the Chief Diversity Officer for Johns Hopkins Medicine, and I just want to welcome you to our inaugural Equal Access in Science and Medicine symposium series. This is going to be at least biannual and perhaps more frequently if we can. There's certainly a lot to discuss in this arena, but certainly we're very happy to have this inaugural program. And I think what's really unique about this is that this is a program that one of our graduate students and postdoctoral fellows brought to my attention not too long after I had started my role as Vice President for Diversity and Inclusion. And, it's interesting because I think in each of our lives, we have a diversity story that evolves as we live our lives. And so this is the 30th anniversary of the Americans with Disabilities Act. And I was a first-year medical student when that was passed. And as I reflect back, you never know in life what things that are going on in sort of the rest of the world that are going to impact you directly and personally. So when I was a medical student in 1990, I didn't know that in 2020 that my mother would have Parkinson's disease, and that she would need a walker and occasionally a wheelchair to get in and out of public spaces. And so I'm very grateful for the adaptations to hotel rooms and bathrooms and all of those things, because you just never know exactly where you're going to find yourself in life and what issues are going to be necessary. I think what's also important to recognize, though, is that in addition to the physical disabilities, there are also mental health issues that can create disability, and many times people are maybe ashamed because unfortunately society has treated mental illness in that way, but we're in a medical environment. So for many years I did research on the link between diabetes and depression, and I would explain to my patients with diabetes that if you have hypertension, we're going to treat you with blood pressure medicines. So if you have depression, then we're going to treat you with an SSRI or whatever else it is that you need. And so I think it's really important that we begin to think about the whole spectrum of disabilities and how we can address them so that we can make sure that everybody who's affected by them can adequately participate in society. And that's really the inclusion piece, and participate in a way that they bring value to our larger society and also to our organization. And I will steal a quote from my colleague, Dr. Bonnie Lynn Sweetnor, and so she always says that disability is the one minority group that any of us can join at any time and unexpectedly. So I think it's really important to remain open-minded about that, and to also recognize that that also creates intersectionality. So most people who have a disability have some other diversity dimension that may impact their ability to interact fully with society. So I just want to welcome you, and then I want to introduce Claire Bell, who's a Ph.D. student in our Department of Genetics, and this was really, she was some of the brain power behind this, and I'm very grateful. I have a son who's a junior in college, and I think that it's the younger generation that really teaches us what it is that we need to know, and that's one of the fabulous things about being in an academic institution. So I'll welcome Claire to the podium.
Okay, thank you, Dr. Golden, and thank you all for coming to our inaugural lecture of the Equal Access in Science and Medicine series. Before I introduce our speaker, I'd like to recognize the sponsors that have made this series possible with their support, including the Mood Disorders Center, the Disability Health Center, the Students for Disability Justice, the Office of Diversity and Inclusion, UHS Wellness, the Office of Biomedical Graduate Education, the Graduate Student Association, the Diversity Leadership Council, and the Human Genetics Program. And so we're honored to hear from Dr. K. Redfield Jamison today, who will be speaking to us about her professional and personal perspectives on bipolar illness. Dr. Jamison is the Dalio Professor in Mood Disorders and a Professor of Psychiatry here at the School of Medicine. She is co-director of the Johns Hopkins Mood Disorders Center, as well as an honorary Professor of English at the University of St. Andrews in Scotland. She is the co-author of the Standard Medical Text on Bipolar Disorder, and the author of the national bestsellers An Unquiet Mind, a Memoir of Moods and Madness, Night Falls Fast, Understanding Suicide, and Touched with Fire, Manic Depressive Illness and the Artistic Temperament. Dr. Jamison was a 2018 Pulitzer Prize finalist for her biography of Robert Lowell, Setting the River on Fire, Genius, Mania, and Character. She is a fellow of the American Academy of Arts and Sciences and the Royal Society of Edinburgh, and recipient of the Lewis Thomas Prize, the Sarnet Prize for the National Academy of Medicine, and a MacArthur Award. And so now please join me in giving an enthusiastic and warm welcome to Dr. K. Jamison.
Thank you. I'm delighted to be here. Thank you to the Disability Office for overseeing this, and particularly to Claire Bell and Carly Rubin for being students who have been energetic, enterprising, and pulling it all together. It's a lot of work, and they've done it remarkably well. So thank you all. I'd like to start by just making one general remark, which is that mood disorders are really common, and the age of onset is in the student years. The usual age of onset is in the student years. So that means that here at Hopkins, as every other university, college, medical school, graduate school in the world, there's going to be a very high rate of depression and bipolar illness. And this is not often recognized by the university administrations in terms of allocation of resources. But I think it's particularly important to be focusing on, this program is put together by 2 postdocs. And we often focus on, for example, suicide rates in undergraduates, because we think, well, one reason is that the colleges and universities focus on that, but also they're a much more homogeneous group. By the time you become a postdoc or a Ph.D. student, you are really on your own, you're more left to your own devices, and we know that the suicide rates are really much higher in that group, and it's a very real problem. But the very diversity and the very range of campuses and so forth and geographic facilities for postdocs and PhD students makes them less accessible often to services. So I'd like to just say great for focusing on this group as well as on medical students. We tell our medical students, every year that a lot of you are going to get depressed. That's just the way of it. Depression is really common. It's the illness that's certainly going to be the most common illness that has the potential to kill you. It's also very treatable. And so what we ask people to do is get treated. I mean, that we will do everything possible to get people into good care. There's every reason to expect that people will respond very well to care, but that we can't have impaired doctors. So we try and make the gradient such that people seek care rather than avoiding care. And I think this is very important. So the one thing I would say over and over again is depression and bipolar disorder are treatable. And to try and keep your wing out for your fellow students or your fellow faculty. So I'm going to just be talking today about my own experiences with mania and depression, a little bit about what it feels like to be manic, a little bit about what it feels like to be suicidally depressed, but also what happens to you when you resist the idea that you need treatment. Because 50% of people who have bipolar illness will stop medical treatment against medical advice. It was something I did, and it nearly killed me. And it's something that can be catastrophic if it's not checked. So let me just start with my own experiences. When I was 17 years old and a senior in high school, I became psychotic for the first time. I had my first major breakdown. I didn't get treated. People didn't have any words really, or nobody I knew had words, despite the fact that I certainly had it in my family, for mania or depression, or the word bipolar was, would have been incomprehensible. Up till the time I got sick, I had been very outgoing, captain of all my teams, loved everything, couldn't wait to leap out of bed in the morning, full of energy, bright-eyed, bushy-tailed. And when I became depressed, I had no idea what was happening. It was so completely at variance with everything that I knew about myself. So I knew I was sick, but I didn't know I was sick. And that's one of the things about mental illness is that you may know that you're not right, but you don't necessarily know that you're ill. It took me a while to figure that one out. So I got better, finally, by the time I graduated from high school. Through college and graduate school, I was up and down a lot, had a great time, had a lot of nightmare months, a lot of great months. And then when I joined the UCLA faculty in the Department of Psychiatry as an assistant professor, within 3 months, I was stark ravingly mad. I was manic, and it was a medical emergency, so there was no question of getting treated. So I got treated about 10 years after I was first ill, which is not that unusual for this particular illness. I was put on lithium. I had a very good doctor, still do. I was put on lithium, responded very, very well to lithium. Still do, fortunately. And then, like I was saying, about 50% of people, I fit right into that category. I'd been brought up in an Air Force family. My father was a pilot and a scientist, and I was an Episcopalian, and those things turn out not to be really very helpful in terms of getting treatment or acknowledging that you have problems or in any way saying that you should reach out to anybody else for help. You know, they're probably pretty good values in general in terms of self-reliance. They're not great values when you're sick. So I was horrified that I was on medication. I was horrified that I was ill. I was terrified of the future. And so I stopped my medication. And I nearly killed myself. So let me just start with starting at UCLA on the medical school faculty. When it's 2 o'clock in the morning and you're manic, even the UCLA Medical Center has a certain appeal. The hospital, ordinarily a cold clotting of uninteresting buildings, became for me that fall morning, many years ago now, a focus of my finely wired, exquisitely alert nervous system. With vibrissae twinging, antennae perked, eyes fast-forwarding and fly-faceted, I took in everything around me. I was on the run. Not just on the run, but fast and furious on the run, darting back and forth across the hospital parking lot, trying to use up a boundless, restless, manic energy. I was running fast, but slowly going mad. The man I was with, a colleague from the medical school, had stopped running an hour earlier and was, he said impatiently, exhausted. This, to a saner mind, would not have been surprising. The usual distinctions between day and night had long since disappeared for the two of us, and the endless hours of scotch, brawling, and fallings about in laughter had taken an obvious, if not yet quite final toll. We should have been sleeping or working, publishing, not perishing, reading journals, writing in charts, or drawing tedious scientific graphs that no one else would ever read. Suddenly, a police car pulled up. Even in my less than totally lucid state of mind, I could see that the officer had his hand on his gun as he got out of the car. "What in the hell are you doing running around the parking lot at this hour?" he asked. My few remaining islets of judgment reached out to one another and linked up long enough to conclude that this particular situation was going to be hard to explain. My colleague, fortunately, was thinking far better than I was, and managed to reach down into some deeply intuitive part of his own and the world's collective unconscious and said, "We're both on the faculty in the psychiatry department." The policeman looked at us, smiled, went back to his squad car, and drove away. Being professors of psychiatry explained everything. Within a month of signing my appointment papers to become an assistant professor of psychiatry at UCLA, I was well on my way to madness. Within 3 months, I was manic beyond recognition and just beginning a long, costly personal war against a medication that I would, in a few years' time, be strongly encouraging others to take. My illness and my struggles against the drug that ultimately saved my life and restored my sanity had been years in the making. For as long as I can remember, I was frighteningly, although often quite wonderfully beholden to moods, intentionally emotional as a child, mercurial as a young girl, first severely depressed as an adolescent, and then unrelentingly caught up in the cycles of mania and depression. By the time I began my professional life, I became both by necessity and intellectual inclination a student of moods. It has been the only way I know to understand and indeed to accept the illness I have. It has also been the only way I know to try and make a difference in the lives of others who also suffer from mental illness. The disease it has on several occasions nearly killed me, does kill tens of thousands of people every year. Most are young, most die entirely unnecessarily. But my manias, at least in their early and mild forms, were intoxicating states that gave rise to great personal pleasure, an incomparable flow of thoughts, and a ceaseless energy that allowed the translation of new ideas into papers and projects. Medication not only cut into these fast-flowing, high-flying times, they brought with them intolerable side effects. It took me far too long to realize that lost years and lost relationships cannot be recovered. The damage done to oneself and others cannot always be put right again. And that freedom from the control imposed by medication loses its meaning when the only alternatives are death and insanity. The war that I waged against myself is not at all an uncommon one. The major clinical problem in treating bipolar illness is not that there are not effective medications, there are. It is rather that patients so often refuse to take them. Worse yet, because of a lack of information, poor medical advice, terrible stigma, or the fear of personal and professional reprisals, they do not seek treatment at all. Bipolar disorder distorts moods and thoughts, incites dreadful behaviors, destroys the basis of rational thought, and too often erodes the desire and the will to live. It is an illness that is biological in its origins, genetic, yet one that feels psychological in the experience of it. An illness that is unique in conferring some advantage and some pleasure, yet one that brings in its wake almost unendurable suffering, and not infrequently, suicide. I am fortunate that I have not died from my illness, fortunate in having received the best medical care available, fortunate in being able to afford to pay for that medical care, and fortunate in having the friends, colleagues, and family that I do. Because of this, I have in turn tried as best I could to use my own experiences of the disease to inform my research, teaching, clinical practice, and advocacy work. I had many concerns about publicly discussing my illness. Clinicians have been, for obvious reasons of licensing and hospital privileges, reluctant to make their psychiatric problems known to others. These concerns are well warranted. I had no idea what the long-term effect of discussing such issues so openly would be on my personal and professional life, but whatever the consequence, they were bound to be better than continuing to be silent. I was tired of hiding, tired of misspent and knotted energies, tired of the hypocrisy, and tired of acting as though I had something to hide. One is what one is, and the dishonesty of hiding behind a degree or a title or any manner and collection of words is still exactly that, dishonest. Necessary, often, but dishonest. I continue to have, every day, concerns about my decision to have been public about my illness. But one of the advantages of having this particular illness for so many years is that now very little seems insurmountably difficult to me. Much like crossing the Bay Bridge when there is a storm over the Chesapeake, one may be terrified to go forward, but there is no question of going back. I find myself somewhat inevitably taking a certain solace in Robert Lowell's essential question, yet why not say what happened? Writing and talking in a personal way about bipolar illness began for me with teaching. For years, I had been director at the Mood Disorders Clinic at UCLA, and it had become clear to me and to the other faculty teaching in the clinic that the psychiatry residents and clinical psychology interns were not on intimate terms with the subjective experience of mania, depression, or their treatments. Diagnosis, yes. Which drugs to prescribe? Generally, yes. But not what psychiatric illness actually felt like to those who have it. So I wrote 2 brief passages many years ago now, and anonymously at the time, of course, for the residents and other trainees in our clinic. I limited each of the passages to approximately 2 paragraphs, as I assumed that was about the limit of the residents' attention span. A general estimate, as those of you who teach or are residents will appreciate. One was a general overview of bipolar illness, and the second was a description of some of the less than altogether delightful aspects of taking lithium. So the first is one person's summary of this illness, namely my own. There is a particular kind of pain, elation, loneliness, and terror involved in this kind of madness. When you're high, it's tremendous. The ideas and feelings are fast and frequent, and you follow them until you find better and brighter ones. The right words and gestures are suddenly there, the power to captivate others, a felt certainty. There are interests found in uninteresting people. Feelings of ease, intensity, power, well-being, and euphoria pervade one's marrow. But somewhere, this changes. The vast ideas are now too fast, and there are far too many. Overwhelming confusion replaces clarity. Memory goes. Humor and absorption on friends' faces are replaced by fear and concern. Everything previously moving with the grain is now against. You are irritable, angry, frightened, uncontrollable, and enmeshed totally in the blackest caves of the mind. You never knew those caves were there. It will never end, for madness carves its own reality. It goes on and on and on, and finally there are only others' recollections of your behavior, your bizarre, frenetic, aimless behavior. For mania has at least some grace in partially obliterating memory. What then, after all the medications, the psychiatrist, the despair, the depression, and the nearly lethal overdose? All those incredible feelings to sort through. Who's being too polite to say what? Who knows what? What did I do? Why? And most hauntingly and always, when will it happen again? Then too are the bitter reminders. Medicine to take, resent, forget, take, resent, and forget, but always to take. Credit cards revoked, bounce checks to cover, explanations due at work, apologies to make, friendships gone or drained, a ruined marriage. And always, when will it happen again? I wrote as well about the difficulties in taking medication because so many of the young doctors in our clinic found it incomprehensible and infuriating that patients would stop taking drugs that so clearly worked against devastating illness. I was first treated in the early days of lithium, or the early days of FDA-approved lithium in this country, and I was treated, as was everyone, at very high doses. The kind of high doses that meant I walked into walls, I slurred my speech, I vomited in public spaces, I ended up in the emergency room night after night after night, getting hydrated. I mean, so it was not, just side effects. It was pretty interfering with my academic life, to say nothing of my personal life. Now, but I didn't have any choice. I mean, it was very clear that I didn't have any choice but to take it. Now, people are kept at much lower levels, including myself, and I, in essence, have no side effects. It's a very different situation now, thank God. And other medications are available for bipolar illness and depression, although lithium remains the gold standard. So anyway, this was sort of something I put together for my psychiatrist, who I have to put in the context of being an incredibly wonderful doctor, but he got a certain amount of the grief and sorrow that I felt about my medication. So this is called Rules for the Gracious Acceptance of Lithium into Your Life. 1, clear out the medicine cabinet before guests arrive for dinner or new lovers stay the night. 2, remember to put the lithium back into the cabinet the next day. 3, Don't be too embarrassed by your lack of coordination or your inability to do well the sports that you once loved so much and once did with such ease. 4, nod intelligently and with conviction when your physician explains to you the many advantages of lithium in leveling out the chaos in your life. 5, be patient when waiting for this leveling off. Very patient. Reread the book of Job. Continue being patient. Contemplate the similarity between the phrases being patient and being a patient. 6, try not to let the fact that you can't read without effort annoy you. Be philosophical. Even if you could read, you wouldn't remember most of it anyway. 7, accommodate to a certain lack of enthusiasm and bounce that you once had. Try not to think about all those wild nights you once had. Probably best not to have had those nights anyway. 8, always keep in perspective how much better you are. Everyone else certainly points it out often enough, and annoyingly enough, it's probably true. 9, be appreciative. Don't even consider stopping your lithium. 10, when you do stop, get manic, get depressed, expect to hear 2 basic themes from your family, friends, and healers. But you were doing so much better, I just don't understand it. I told you this would happen. 11, restock your medicine cabinet. So it's hard enough to keep, as my husband, Tom Trail, who's a cardiologist here, points out, it's hard to keep anybody with a chronic illness on medication and a treatment program. It's particularly hard when you have an illness that you get quite young and that confers some advantage or perceived advantage. So I just want to talk a little bit about that perceived advantage before talking about the disasters. So bipolar illness is complicated. It laces together loss with advantage and places despair in close proximity to great pleasure. It is difficult to convey how powerful the allure of mild mania can be. But let me describe the beginning of one manic episode, which was a trip I took to Saturn unaccompanied by spacecraft. This was out in Big Sur on the beach, and it was extraordinary. So people go mad in idiosyncratic ways. Perhaps it was not surprising that as a meteorologist and as a pilot's daughter, I found myself in that glorious illusion of high summer days, gliding, flying, now and again lurching through cloud banks and ethers, past stars, and across fields of ice crystal. Even now, I can see in my mind's rather peculiar eye an extraordinary shattering and shifting of light, in constant but ravishing colors laid out across miles of circling rings, and the almost imperceptible, somehow surprisingly pallid moons of this Catherine wheel of a planet. I saw and experienced that which had been only dreams or fitful fragments of aspiration. Was it real? Well, of course not. Not in any meaningful sense of the word real. But did it stay with me? Absolutely. Long after my psychosis cleared and the medication took hold, it became a part of what one remembers forever, always, surrounded by a Proustian melancholy. Long since that extended voyage of my mind and soul, Saturn and its icy rings took on a private beauty to me. And I don't see Saturn's image now without feeling an acute sadness as being so far away from me, so unobtainable in so many ways. The intensity, glory, and absolute assuredness of my mind's flight made it very difficult for me to believe, once I was better, that the illness was one I should willingly give up. Even though I was a clinician and read the research literature, and indeed wrote some of it, and I knew the inevitable bleak consequences of not taking lithium, I, for many years after my initial diagnosis, was reluctant to take medication as prescribed. Why was I so unwilling? Why did it take having to go through so many episodes of mania, followed by long suicidal depressions, before I would take lithium in a medically sensible way? Certainly there were real and unpleasant, not to say disruptive, side effects. But much of my reluctance stemmed from a fundamental denial that what I had was a real disease. This is a common reaction that follows rather counterintuitively in the wake of early episodes of mania and depression. Moods are such an essential part of the substance of life, of who one is, of one's notion of oneself, that even psychotic extremes in mood and behavior can somehow be seen as temporary, even understandable reactions to what life has dealt. In my case, I had a horrible sense of loss for who I had been and where I had been. It was difficult to give up the high flights of mind and mood, even though the depressions that inevitably followed nearly cost me my life. The seductiveness of these unbridled and intense moods is powerful, and the ancient dialogue between reason and the senses is almost always more interestingly and passionately resolved in favor of the senses. I reaped a bitter harvest from my refusal to take lithium on a consistent basis. A floridly psychotic mania was followed inevitably by a long and lacerating black suicidal depression. It lasted more than a year and a half. From the time I woke up in the morning until the time I went to bed at night, I was unbearably miserable and seemingly incapable of any kind of joy or enthusiasm. Everything, every thought, every word, movement was an effort. Everything that once was sparkling now was flat. I seemed to myself to be dull, boring, inadequate, thick-brained, unlit, unresponsive, chill-skinned, bloodless, and sparrow-drab. What is the point in going on like this, I would ask myself. Over and over, I would say to myself, if I can't feel, if I can't move, if I can't love, if I can't think, if I can't write, if I can't care, then what conceivable point is there in living? I reasoned they would kill an animal who was in far less pain. I could not bear the person I had become, and I could bear even less the burden I felt I had become to the many people who loved me. My psychiatrist repeatedly tried to persuade me to go into a psychiatric hospital, but I refused. I was horrified at the thought of being locked up, being away from my friends and familiar surroundings, and having to put up with all the indignities and invasions of privacy that I knew went into being on a psychiatric ward. I was working on a locked ward at the time, and I didn't relish the idea of not having the key. Mostly, however, I was concerned that if it became public knowledge that I had been hospitalized, my clinical work and privileges at best would be suspended. At worst, they would be revoked on a permanent basis, and I would lose my job. At the time, nothing seemed to be working, despite excellent medical care, and I simply wanted to die and be done with it. I resolved to kill myself. I was cold-bloodedly determined not to give any indication of my plans or the state of my mind, and in this I was successful. The only note made by my psychiatrist on the day before I attempted suicide was, severely depressed, very quiet. I took what I knew to be a far greater than lethal dose of lithium. I was a lithium researcher at the time, and I took an antiemetic to keep from vomiting up the pills. I was in and out of a coma for several days and nearly died. As a result, I no longer fight taking lithium. Repeated psychosis and nearly lethal suicide attempt have a way of convincing even the slowest of learners. And I am fortunate to have been able to take some of my own experience into my work. I'm also enormously fortunate to have had the support of the chairman of my department at UCLA and here at Hopkins. When I was at Johns Hopkins, I was an assistant professor. I was a Ph.D. running a medical clinic, which was not wildly popular among some of the medical staff. All the women faculty in psychiatry were in child psychiatry, which is essentially a totally different department. So there were 80 of us in adult psychiatry. There was one woman, me. And I had been psychotic. So the combination of being a psychotic Ph.D., running a medical clinic, meant that my chairman had a lot of really good reasons to say, why don't you choose something slightly less stressful to do? And he didn't do that. He came up to me after my major manic episode, put his arm around me, and he said, hey, kiddo, I understand you got a problem with your moods. And I said, well, that was one way of putting it. And he said, look, just keep seeing your doctor, taking your medication, learn from it, teach from it, write from it. And when I would see him, before I came back to Washington, he would say the same thing, the same mantra, which was learn from it, teach from it, write from it. He never once suggested that I give up my job. He never once suggested I go somewhere else or get a less competitive line of work. He believed in me. He also believed that he could talk to my psychiatrist anytime, because I made that clear. So it's hard to say what kind of support that is to somebody who's just starting off in an academic career when I couldn't read or write because my medication was so interfering with my work. So I'm eternally grateful to the doctor, a man named Jolly West. When I had written my manuscript for my book about my experiences, I went to Paul McHugh here, and I started saying to him, look, Paul, I've written this book about my own experiences. I don't want to put Hopkins in an uncomfortable position. There are a lot of legal issues. There are a lot of educational issues. There are a lot of clinical issues. But the problem is that when people get well who are in the professions and they don't tell the public, what the public sees is the people who are sick. They don't see the people who are successfully treated. And there are hundreds and hundreds and hundreds of thousands of people who go out and compete every day who are well. And so I was kind of mumbling on. And Paul said, you've got it all backwards. When Professor Halstead was here, first chief of surgery, there were several of the faculty who knew that Professor Halstead had addiction to cocaine and to morphine, and took it upon the faculty to first and foremost protect Professor Halstead's patients when he was impaired, but also to protect Professor Halstead so he could continue to teach and train young surgeons. He said, if Hopkins can't do that for you, Hopkins has no business being in business. He set up a luncheon for me with the president of the hospital, Dr. Block, who said exactly the same thing. They both said, we have your back. This is exactly what we should be doing. We should be trying to destigmatize these illnesses. We should be trying to get our own house staff and medical students into treatment here at Hopkins rather than in the community. And they just made life a great deal easier. And indeed, my colleagues here, including Ray DiPaolo, just have made things so much easier. I'm not naive. I know this isn't usual. I mean, I go to a lot of the medical schools here and abroad. It's not usual to get that kind of support. But what it is it's exemplary. And one can always find 100,000 ways where things are done not well. But it's from the exemplary that one learns. And I speak here today because of their compassion. Thank you.